Tell me.
We will wait about 2 minutes for the participants to join us. Okay, Doc, you may start the webinar now. Thank you.
Chat to you.
Okay. Dear colleagues and dear friend, good afternoon. I'm really glad to have this chance for seeing all of you again, because we have had a very bad period and we experienced the worst period of our life, I believe. We lost a lot of colleagues, and for this I want to express now my deepest participation to colleagues from Indonesia for their severe loss. This webinar represents the only one way for sharing now our experience. And I'm glad to ISMINS and all the other organizers for offering this opportunity. We can discuss case, underline our results and even our failure and the advantages, but at least we can be in touch. Minimally invasive spine surgery involves all the techniques that can minimize the damage to the surrounding structures of the spine, I mean muscles and ligaments. These less invasive surgeries are a group of surgeries that allow for the following benefits when compared with the traditional method of surgery. That is faster recovery, faster return to normal life, reduction of blood loss, reduction of infection, and reduction of the pain of the patients. That is one of the most important points. At present, spine surgeons are able to offer a lot of less invasive treatment, and their operating room are kind of a setting of Star Wars, very, very special. They offer endoscopy, esoscopy, spinal intervention with three-dimensional navigation, spinal navigated instruments, possibility to perform CT or MR intraoperatively, and so on. In this webinar, we will have the opportunity of listen to speakers, and all the invited speakers will be dealing with a different technique with his experience, and I express to all of them my deepest gratitude for offering us their experience in so immediate way. I think that I can introduce the first speaker of this webinar, Professor Guisardi, and I ask him to show his presentation.
Thank you, Lucia, and thank you to everybody. And I can say good morning or good afternoon, or for somebody, good evening around the world. And I like to share my presentation with all the colleagues. And if somebody have one question, don't hesitate, because I think that don't exist one stupid question. The question, all the questions are questions, and everybody can learn some from the question of some other colleagues. So I like to share my presentation with you. Okay, can you see my presentation?
No, now?
Not yet.
Not yet. Can you share your slide?
Yes, yes, only one moment,
Yes,
because
we
I
said before.
must come back to Zoom and to share my, okay, share my video.
Okay.
It's okay
coming.
now?
Coming.
Okay.
Okay, open.
Okay, so I can start. And first of all, this is my disclosure. And I'd like to introduce a moment my land, that it's Italy. You look in red, it's Tuscany, it's our region. And I think that everybody know this very, very important city that we have in Tuscany, like Florence, that is well known all over the world, but we have also Pisa, Siena, and everything. But you cannot forget that Tuscany is really very, very famous also for these two very particular things, the oil production and this special type of wine that it's a Chianti. So if you come to Italy, don't forget to test these wonderful things. What we will talk about? We will talk about this new interlaminar interspinous and facet joint stabilization system. And historically, only a moment because I have a problem with the screen. Okay, one moment. Okay. So historically, pedicle screw or facet screw have been the first choice for vertebral fusion. But each of these, however, presents certain risk for the patient since a screw placement is in close to the nerve roots and vascular structure. Furthermore, C-arm fluoroscopy is required to ensure proper screw placement, exposing the patients and surgical team to high levels of radiation. And from 2014 start to appear, after not a very good result with some of this motion preservation device, start to appear on the market this interspinal stabilization system. And at the same moment, and in a short time, a big number of papers was published in the medical journal. You look a little example of that. But they all are not used standalone. So they must use it in combination with the screw, monolateral, bilateral, with the interbody cage, and so on. I like to share with you this situation. You look at, this is on the left side, is the natural, the motion of the level 4-5. And you look the motion of the facet joint, and you look how is big the range of motion of the facet joint. You can look very well. And so we know well that at the beginning of the life, the load of the spinal unit is 80% on the anterior column. But you know that during the life we have this degenerative cascade or this disc degeneration. And we have also a big changes because we have a facet joint degeneration under load. You look, this is a classification. For this reason, in the time, the load move posteriorly. So now when we have this problem of this overloaded facet joint, the problem is generally posterior column and not more in anterior column. For this reason, I and Dr. Petrini, my friend, 10 years ago, this picture is from 10 years ago, don't forget. And we start to think to a new device, to a new system to stabilize the spine. And this is this new device that we invented, that it's, the name is Ischia and Filicudi. Ischia and Filicudi is the name of two very, very nice Italian islands. And on this situation, if you like, you can put also each type of cage, so you can do in this type of instrumentation, you can perform also a 360-degree arthrodesis. Following this biomechanical concept, we use this system for these reasons. Depending on patient condition, anatomy, age, and activity level, implantation of interspinous and facet joint fixation system show a construct stability comparable to pedicle screw, but with fewer risks. Double system for primary stability of the device, interspinous interlaminar and facet joint system. Contact bone to bone and not bone titanium to obtain a kind of biological fusion. And if you need, you can use a ligament to compress the bone and restore the lordosis. Which are the characteristics? This cage, see, both cage, interlaminar, interspinous, and facet joint are 3D printed cage with a special type of titanium. You look, this is this special type of titanium that can increase and can promote the intervertebral fusion with one increasing on the newborn formation. It's really a special type of titanium. Naturally, we start many years ago with cadaver and lab test before to have, and these are the implant. You look, these are the implant before the less cleaning, and you look at that it's really a very particular material. This is the CE mark that we obtain, and after that we can start with to implant the material in the people. This is the first stage. You must have a surgical technique. You must perform a median incision of the skin approximately of 4-6 centimeters. You must dissect the paraspinal muscle laterally to the supraspinous ligament. You must detach the supraspinous ligament, remove the interspinous ligament, and dissect the ligament from the subperiostal spinous process or along a portion of the interspinous process bone, as per the surgeon preference. If you need or if you like, you can perform the decompression and you can prepare the home for the implant. Cleaning, this is very important, cleaning and gently removing the superficial part of the cortical bone where it's in contact with the implant to increase the surface of the contact. This is another very important point of the surgical technique. You must control well preliminary to the surgery using the CT scan axial view of the level that you must treat, and keep in your mind the direction and orientation of the facet joint, because they are very, very different from level, and also in two levels on the same patient, the orientation is completely different. So it's very important to look before, which is the orientation of the facet joint. At this point, you must prepare the facet joint. You must open the capsule and search the right interfacet line. Mobilize the segment can be very helpful to well identifying the entrance. You must use the recurved curettes and rasp to enter into the articulation. Bloody the facet joint surface and prepare the home for the articular cage. This on the right are the instruments that we use. At this point, we come back to the midline. You must use the implant trials, differentiate this one another of 2 mm from 8 to 14 mm in order to define the most adequate implant size. Introduce the trials as anterior as possible up to the interlaminar space. Fill the ischia, that is the interspinous interlaminar cage, in a space with biological material and press with the instrument. Don't forget that you must press the bone chips that you put inside, because if the bone is not compressed, you cannot have a good arthrodesis. At this point, you must do the same. You must feel the same for the articular cage. The articular cage are two sides. The first side is 5 millimeter. The biggest side is 7, because 7 we use when we like to reduce one lysthesis. At this point, you must put the cage in between the two facet joints. This is one control that I like to show you. You look at that is on the operating table. But what is really nice, look, I don't know if you can see my arrow, no? You look that the two facet joints are completely on the same line in the lateral view. And this is the posterior cage. And you look inside, this different density, this is the bone that we put inside. This is another case that it's a very recent case. You look on the right, this is the lysthesis in old patients with one adjacent segment disease 12 years after the first fusion on the level 3-4. You look, we have really a very good sleeping. And this is the control on the same table after the procedure. And you look, we are able to reduce quite completely, perhaps 1 or 2 millimeters, the lysthesis that we have before. This on the right is before, and this is after the surgery, before to wake up the patients. This is one 3D reconstruction control that you look in which we can see very well a very nice arthrodesis in between the two spinous processes. In this case, we put one interlaminar motion preservation device above and below to prevent the adjacent segment disease. This is another case, and you look at 3 months after the surgery, we have really a very, very nice arthrodesis in between bone of the spinous process and the bone inside the cage. And this is the same that we obtain. We look, we have some bone around the facet joint cage. This is another case with a very good fusion. This is on the level 5-1. Look inside the cage. The bone is in contact completely with the spinous process adjacent. And this is one wonderful case. Look what's happened on the facet joint. You look this bone formation around the cage. And so we have really one also arthrodesis of the facet joint. So I think that I don't need to spend more time. I prefer to let the time for the discussion if you have some questions. And this is a paper that we are publishing on this moment. And I like to show that we perform all procedures that we performed without any complication, with an average surgical time of 93 minutes. At the term of each procedure, the correct position of the implants was confirmed by X-ray. During the post-operative period, the surgical wound dehiscence was reported in 3 patients and the reoperation in 3 patients. From the clinical outcome, we have really a very significant improvement following lumbar surgery were observed. Improvement was documented by BAS on the leg pain and on the back pain. Only 4 patients was not satisfied and not recommend the surgery. And finally, I like to say that this interspinous, interlaminar, and facet joint implant associated with bone grafting provided vertebral fusion in masked stenotic patients with grade 1 lysthesis undergoing decompression. At 1 year follow-up, all patients with fusion, pre-operative had chronic back pain, exhibited a highly significant improvement in all outcome measures, indicating a satisfactory clinical result. And no had any increases in all lysthesis. This is, I think, it's another very important point. Or showed increase in the stability of the slipped vertebra. For sure, a biggest number of patients and the longer follow-up will be for sure requested to validate completely this new device. But this missed surgery is currently very encouraging and satisfying. We are strongly motivated to continue on this experience, especially for the very low morbidity for the patients, for the minimal invasive surgical procedure, and for the high grade of patient satisfaction. So I like to thank you, everybody, for your attention. If you need some, you can look at this is my personal email. You can write me if you need some. I can send you and I can answer to all your questions if we have done time now. Thank you very much. No, Lucia, you have your microphone is out.
Riattiva l'audio. Ecco.
Okay.
Thank you, Professor Guicciardi, for your nice presentation. Are there any questions from the panelists or from the audience?
So far, we don't have any question from the chat box. So we have two options. Either we continue with all presentation, then we have a very long discussion session.
Okay.
Okay.
Okay, we can do it. Okay. Now is Professor Bajamal that will present his paper about lumbar microscopic decompression with presenting his result. Professor Bajamal.
Assalamualaikum warahmatullahi wabarakatuh. Dear all, first I would like to thank Dr. Asra Al-Fawzi and his team, the coordinator of this webinar, for the opportunity given. And glad to join the speakers to this evening with my colleague, Professor Guicciardi and Dr. Sanjal. Hello. Also to the moderators, my colleagues, Dr. Azmi Ilyas and Dr. Benvenuti. Nice to meet you. I'm not forget to say hello to Professor Yoko Kato, the president of ISMINS. Dear Professor Kato, may God bless you all. I will present microscopic decompression for lumbar spine stenosis, especially about the technique and pitfall. This technique already known since 1954, report by Valgelden and Verbies from Nederland, and they explain the exact myelographic image of the spinal stenosis. Lumbar sacral stenosis gives a significant impact to the health of population because it is impact the activity, daily living, integration of clinical problem, which make disability for the patients. This disease increase in old age and estimated nearly 20% of general population will have lumbar spinal stenosis. And still, non-surgical management should be given to the most patients. As we know, lumbar spine stenosis is a slow degenerative process as a result of aging process, activity during life, and genetic factors. The important is that the pathology can be in one level, but also can be multi-level. Multiple degenerative changes include bulging disc, osteophyte formation, facet hypertrophy, thickening of lavum, foraminal stenosis, and causing nerve pinching, and give radicular pain to the leg and walking disability. Although like that, it may still be asymptomatic. We can see exactly in this slide the changes from normal anatomy to degenerative. The canal in a normal compared with this, the facet, and the flavum, and the disc, and the lateral recess stenosis. So
webinar series, and we also
this is important that clinical diagnosis can easily based on history and symptom and the progression of the symptom. We call it neurogenic claudication. Patient typically complain of unilateral or bilateral leg pain, numbness and weakness that can be precipitated by standing or walking for a long time, and the symptoms reduce in lumbar flexion, sitting or lying. Vascular claudication should be differential diagnosis. One also, we have to keep in mind that no direct correlation between imaging findings and clinical symptom. After clinical diagnosis had been made, then we proceed to imaging diagnosis. We have several important points. X-ray is important in standing position and dynamic X-ray, mandatory to evaluate alignment, to see the corpse line, coronal and sagittal corpse line angle, and also to evaluate this condition. This is sagittal corpse angle measurement, that is coronal measurement of the corpse angles, and also segmental corpse angle. And you can see also the foramen, the disc height. Discuss about the foraminal height. Then you can see this is a classification from Kunogi and Hasu. There are 3 types of foraminal stenosis. You can see this picture different between 4.5 and 5.1. You see this is a circumferential stenosis. Now, MRE will give appropriate and non-invasive figure and beautiful pathology changes you can see. First is this degeneration and this facet hypertrophy, and then ligamentum flavum hypertrophy and canal stenosis. You can measure the canal condition. This, in this picture, you can see this is partial obstruction, this is nearly total obstruction. And also you can see the foraminal normal and the foraminal stenosis 2 levels above, which can give an impairment of nerve roots. There is still question whose answer determine our way of thinking. Is degenerative changes a simple pathology? If you see the progression of the pathology, then this is the progression you can see, and the result is complex pathology. For the long term, the result is complex pathology. But even in the old age, a different patient at the same age, they give a different figure of the degenerative process. In for this kind of patient, you see that this is normal, canage normal, this normal, only hypertrophy of the facet. But in this kind of patient, you see the flavum is hypertrophy, the disc protruded, foramen stenosis, and hypertrophy of the facet. We go to the next is surgical indication. All patients after underwent conservative treatment, then from the conservative treatment, it found, according to Sheol in 1996, only 15% improved by the non-surgical management. and later on found that nearly 85% not improved conservative therapy, 75 similar symptom, and 15 reporting worsening symptom. Now, persistent recurrent nerve claudication, radicular pain, limb weakness, bowel problem, and neuro abnormality and conduction studies abnormality also you can find. But the important thing is we have to always correlate the appropriate level, site of neural compression, reveal, and the MRI image. Surgery is usually scheduled, but the main reason to improve the quality of life. But if the condition rapidly deteriorates, such bladder or motor problem, emergency surgery should be performed. What kind of approach? There are two kinds of approaches: open conventional approach and minimal invasive approach. In minimal invasive, they can be consist of microsurgical decompression, insertion of spacer, microendoscopic, and percutaneous stabilization. Now, open surgery technique is a standard technique, actually. Let us have a look at the report of famous neurosurgeon from Swiss. Let's see the standard technique is still must be based on the principle mastery of anatomy, leveling the arm, gentle tissue handling, maximal facet, ligament protected. Let's see the results, the report from the famous Switzerland neurosurgeon with follow-up up to 6.5 years with 72 retrospective patients. The result is decompressive by Lamingtomy with undercutting the facet joint is safe procedure with low rate of secondary instability. So there is a high incidence of excellent or good long-term result for the conventional open decompressive laminectomy. We are going to talk now about a micro-unilateral approach for bilateral decompression. From this figure, the CT scan clearly visible. With this technique, the canal is well decompressed. Now, there is another choice of approach, chimney sublaminar decompression, splitting through the spinous process, going inside to the canal and the foraminal. And also decompression and fusion in special indication in case of spondylolisthesis and evidence of instability of kyphosis, or if there is a risk of non-union when only treated by posterior fusion. So if there is no deformity and instability, it is mean that there is no fusion recommended. Now, this is the essential instrument for the microsurgery of decompression. Carison, high-speed drills is the important thing, delicate periosteal elevator, nerve hook, bipolar forceps. This is the essential, beside the basic and the chosen retractor. As the decision to operate has been made, mandatory to determine the optimal surgical site opening, which side, left or right. And the positioning is very important. It's crucial factor for success of surgery. And then confirmation of the fluoroscopy, and then beginning skin incision, insertion retractor, and treatment of the bleeding, and once again check the C-arm level, and going to the bone work, Hemi-Laminotomy is wide enough to perform microsurgery. This is wide enough. This is Hemi-Laminotomy. You don't need total laminotomy. Hemi-Laminotomy like this with preserve of the facet in the upper part and the pars. You can go through the 5mm tip Rosenbohr first, and then going internal layer compact bone with 3 or 5 mm diamond, in going further to the facet inside, and then recessus. And after that, maintain the flavum until completion of the wound work. So don't access the flavum. This is to prevent dural injury. If it is too thick, then hinders the work. It can be thinned out. Start ipsilateral decompression, decompression first ipsilateral and then going to the another side. And during excision of the flavum by Carrison, don't forget to place a small cotton, delicate cotton, between the dura and flavum before excision to prevent the dural injury. Now, let's see the micro-bilateral hemi-lamingtomy for bilateral decompression. This is in a severe case where both facet is very hypertrophy. Sometimes it's difficult if you're going through unilateral. If you find that this is true to both lateral, then you can do like this, both side hemi-laminotomy. Let's see the video. First, use 5mm tip of the Rosen and continue with 3mm. And in the deep side, maybe you can use 1mm diamond bore. And going to another side with 5mm Rosen, and in deeper part going with 3mm diamond bore. And during in the recesses, you can use 1mm diamond bore. So this is the result, bilateral decompression. Now, let's see the step-by-step of the processes of the bone work. After laminotomy by Rosenbohr, and then a recessus ipsilateral, and the facet, thinning of the facet in the ipsilateral, and then going to midline, unroofing a part of spinous process in lamina, and then going to the recessus and foraminal contralateral, and this is finished. The ligamentum flavum still intact, and then going to the next. This is the video. You see the beginning of laminotomy and recessus and foramen on ipsilateral side, and then unroofing the lamina process spinosus, going to the recessus and foramen of another side. So the important thing is maintain the flavum and use a delicate small respiratorium to make a space for drilling. Now the complication, this is neurologic complication about 1–2%, dural injury about 10%, infection is about 2%, hematoma 0.6, instability can be happen, it's about 20%, reoperation 15%, and there is a medical complication depend on the condition of preoperative of the patient, including venous thrombosis 5 to 10%. Now let's learn about pitfall. The pitfall actually can be avoided by proper patient selection, good preoperative planning and approach, optimal patient positioning, and exact localization. understand the basic knowledge, and discuss about difficulty with the expert. Now, I recommend you routine whole spine MRI and dynamic X-ray because many other disorders are asymptomatic and or masking by symptom of canal stenosis like OPLL, OLF, tumor, and instability. The important thing is a risk factor. It can jeopardize your name because of the impact on complication in outcome. Likewise, the risk factor. Next is, you see, this is example concomitant disorders in 3-4 small mild lysthesis with canal stenosis, and you see there is also a stenosis on the 11-12, and also the importance in be careful of possible of deviation of spinous process. From in this kind of problem, you have to go through this way for laminotomy, not this way. Now, it is impossible by analyzing the drug, we can determine the best surgical. That's why a review your literature, you can find that it is very difficult to compare because many differences in clinical condition and symptom, patient anatomy changes, surgeon experience, techniques, and patient satisfactory. Micro-decompression, however, achieve at least the same as clinical result and cost-effective as open surgery. Unilateral show excellent result for clinical improvement, overall satisfaction, as well as low morbidity. But if you compare transforaminal endoscopy and microdiscectomy or micro-decompression, it is most of the literature say that the comparable. There is a different result. There is a different in satisfaction, different in time, operating time, different in blood, but most are comparable. Endoscopic decompression have a steep learning curve so that stable outcome can be achieved after the acceptable number of cases. Studies report that the learning curve is completed after 40 cases for interlaminar approach. Now, I conclude this presentation is surgeons should make a strong determination as to which approach will be best for the patient. Small incision does not mean a small surgery, and even if the operation is minimal invasive, it must not be done by an insufficient operation and inadequate decompression. And it is important also, it is really does not matter what technique you use to decompress the nerve root. But if you fail to fully decompress the nerve root or introduce some complication, you have failed to serve the patient. You have to think, although, to consider the balance between adequate decompression, prevention instability, and preservation of function. It will make error on either side, and it will add complications. And it's important to know what are the demand and expectations of the patient before the surgery, and you have to prepare for that. So the micro-decompression is effective for the lumbar spine stenosis with patient in moderate and severe symptom. For the mild symptoms, still conservative. And observation. The initial benefit of a surgical decompression may decline over time due to the fibrosis, restenosis, or the degenerative process. So the longer follow-up is very important. And the responsibility as a surgeon to keep supervision, education for the patient in order to keep the healthy patient, healthy spine of the patient. Thank you very much.
Lucia, can you continue?
Yes, I want to continue. Allora, the next speaker will be Professor Yoniki Mizuno. He will present. No?
There is slight changes. Professor Mizuno could not make in the very last moment, and we are very happy that we have Dr. Sujoy Kumar. Yeah, he will present on his topic.
Present you.
Okay, how?
Oh.
So can I speak now?
Yes.
Okay. So, it was a last minute change. I got changed from being a moderator to being a speaker. Okay. It's evening here in Calcutta in India, and warm greetings to all of you. And I'm really thankful to Professor Bajamal, Azmi, and my friends, Asra, and all of you for having, for having organized this webinar and for having given me an opportunity to speak here. So I will get on to my topic straight away. Okay. Okay, can you see my screen?
Yes, perfect.
Okay, so I'll be talking about I'll be talking a little bit about accurate placement of percutaneous pedicle screws, and thereafter I'll be moving on how I use percutaneous pedicle screws and a minimal access approach to treat cases of spondylolysthesis. As many of you may be knowing, I work in Calcutta, which is the largest city of the eastern part of India. Okay, now I actually have stopped placing open pedicle screws for the last 12 years of my practice. In the last 12 years, I have not placed a single open pedicle screw. I place all my pedicle screws percutaneously, and I use a small trick to place my pedicle screws percutaneously in an accurate fashion. So I just do some, I get a CT scan of the spine done, and I do some pre-operative planning. So, on the axial slices, I simulate the screw insertion from the skin through the pedicle into the vertebral body. So I do the simulation on the axial images of the CT scan, and thereby we measure the distance from the midline of the skin incision or the screw entry point. So we measure the distance from the midline, and we also measure the mediolateral angle at which the screw will enter from the skin through the pedicle into the vertebral body. And once we have measured that mediolateral angle, we replicate that mediolateral angle just by using a protractor from our school geometry set, from my daughter's school geometry set. And I use that protractor to replicate that mediolateral angle. This kind of pre-operative planning also allows me to allows me to measure the pedicle diameter, which is important for thoracic pedicle screws. Now, so therefore, I do this pre-operative planning. And after this pre-operative planning is done, actually what is left is, one second, I just wanted to hide this. Okay, yeah. After I do this pre-operative planning, what is left to be done intraoperatively is only the craniocaudal location on the skin of the screw entry point and the craniocaudal angle of the screw. Both of this are determined by the lateral X-ray. So thereby, by doing this pre-operative planning, by doing this pre-operative planning, we actually decrease AP fluoroscopy time. Now, so this is the pre-operative planning. So on this pre-operative planning, we measure the distance from the midline of the screw entry point, and we also measure the mediolateral angle. The craniocaudal location of the screw entry point, and the craniocaudal angle is determined intraoperatively on the lateral X-ray. Now, this accurate preoperative planning actually allows accurate placement of percutaneous pedicle screws, which I will show you. And I have never used neuronavigation for placing my pedicle screws, and I do not have the expensive O-arm technology. In addition, this planning also decreases AP X-ray exposure time for both the patient as well as for healthcare personnel. Now, as all percutaneous pedicle screws, these are placed through small stab incisions, unlike open pedicle screws, which are placed through a large open incision, and there is a lot of muscle retraction involved in placement of open pedicle screws. As I said, I have stopped placing open pedicle screws for the last 12 years. Now, the acid test of whether my preoperative planning really works in practice is actually where for thoracic pedicle screws, because for thoracic pedicle screws, if this technique works for thoracic pedicle screws, then it works for everything else. So I'll show you some images of some preoperative planning and the post-operative CT scans, and you will see that the post-operative CT scans are actually replicas of the preoperative planning. So this is how the preoperative planning looks like, and this is the post-operative CT scan. This is the preoperative planning, and that's the post-operative CT scan. And these are all for thoracic pedicle screws. So that's the preoperative planning for a thoracic pedicle screw, and that's the post-operative CT scan. That's another preoperative planning. That's the post-operative CT scan. Another thoracic pedicle screw. So I'm not showing you the lumbar pedicle screws, because lumbar pedicle screws will be relatively simpler compared to thoracic pedicle screws. So as you can see, that the preoperative planning actually mirrors the post-operative CT scans. And, we have been able to place even screws in scoliotic stenotic spines. This patient had a really scoliotic stenotic spine, and we placed all our screws percutaneously through small stab incisions. And as you can see, this technique works very well. So that's the preoperative planning, and that's the post-operative CT scan. That's the preoperative planning. That's the post-operative CT scan. That's the preoperative planning. That's the post-operative CT scan. And these are the CT images which show that the screws have been accurately placed. This was a high L1, L2 central prolapse who presented paraplegia. Because it was a high disc prolapse, we decided to take out the facets and go from the lateral side while taking out the disc. And we stabilized it by using percutaneous pedicle screws and did the lumbar interbody fusion. This patient's paraplegia improved, and those are the post-operative CT scans showing perfect placement of the percutaneous pedicle screws. Now, post-operative CT scans for percutaneous pedicle screws, we do post-operative CT scans routinely for all thoracic screws, for all high lumbar screws, for curved spines, and for technically difficult cases. We have done actually even more. This was data of 2 years back. Lots of pedicle screws, and we have had no violation in the CT scan after the first 30 screws. In the first 30 screws, we had 3 asymptomatic violations. I mean pedicle violations. Now, all these 3 pedicle violations actually happened when we significantly deviated from the pre-operative planning, and we decided to favor the intraoperative X-rays. So actually, I have come to believe that the preoperative planning is sacrosanct, and that's what we should just believe in. Now, I'll show you how I use percutaneous pedicle screws in a minimal access approach for cases of lumbar spondylolysthesis. Now, this is a preoperative MR of a lumbar spondylolysthesis. So that's the preoperative MR, that's the preoperative X-ray. Now, how we go about treating spondylolysthesis by percutaneous pedicle screws and a minimal access approach, I will show you step by step. In step 1, we place reducible percutaneous pedicle screws on one side. We do not place the rod at this stage. So that's step number 1. In step number 2, we use a small midline incision, and we use the midline incision to do a bilateral laminotomy of the upper slipped vertebra with preservation of the midline. However, if there is severe canal stenosis, we do a laminectomy of the upper slipped vertebra. We do bilateral facetectomy. We do a wide discectomy. Now, if you do all these steps, you actually release nearly all the connections between this slipped vertebrae. So, step number 1, we have placed screws on one side, but we have not placed the rod. In step number 2, we use a small midline incision to release all the connections between the two slipped vertebrae by bilateral facetectomy and a wide discectomy. Now we go back to the screws which we have placed on one side, and we reduce the lysthesis and fix it. Now, so basically there are some tricks involved. We drive the upper screw in as much as possible. We drive the lower screw as less as possible. We place the rod. We fix the rod to the lower screw. We sometimes bend the rod so that the rod is lying high above the upper screw head. Then we use a reduction instrument to reduce the upper screw head to the rod, which is lying high above the screw head. So therefore, the higher the rod initially is above the upper screw head, the more the reduction. So this reduction happens is because we have the step number 2, by means of the facetectomy, bilateral facetectomy and the discectomy, we have released the connections between the vertebrae. So with this we reduce and fix on one side. So that's step number 3. So this is how we started off. This is the pre-op X-ray, and you can see the bilateral facetectomy, and now it's reduced and fixed on one side. So that's after step number 3. Now we go back to the midline. Through the midline, we do a lumbar interbody fusion. So that's number 4. Then we go to the opposite side and place screws on the opposite side as well to buttress the fixation. So that's how we started off. So that's the pre-op X-ray, and that's the post-op X-ray. As you can see, it's reduced and fixed completely. Just a second. Okay. So as you can see, it's reduced and fixed completely. And this is done only through small incisions. Nowadays, we just use a 3-centimeter incision to do this surgery. Now, this is a higher grade lysthesis. When this young girl actually had a grade 1-2 lysthesis in 2014, but when she came to me in 2015, she had a pretty high grade lysthesis, and this was her lysthesis when she came to me in 2015 for surgery. As you can see, this is one bone here, and that's the other bone there. One bone here and the other bone there. That's pretty high grade lysthesis. Again, as I told you, we place screws on one side. We do not place the rod. We go to the midline. We do a bilateral facetectomy and a discectomy. We release the connections between the slipped vertebra. Now, the reason why we place screws in step 1 is because if we do the release as step 1, the bones become loose, and then you will have difficulty in driving the screws in. So that's why we first place the screws, then go to the midline, and then we release the connections between the two slipped vertebra by means of the bilateral facetectomy and the discectomy. Okay, then we go back to the screws which we have placed. We reduce and fix it. So this is how we started off. That's the pre-op X-ray. That's the pre-op X-ray. And this is reduced and fixed on one side. And you can note the bilateral facetectomy, which has allowed the reduction. Then step number 4, as I said, is lumbar interbody fusion. Then we go to the opposite side and place the screws. So this is our pre-operative X-ray. And that's our post-operative X-ray after both sides screws have been placed. So that's the pre-operative X-ray, and that's the post-operative X-ray. It's reduced and fixed completely and done through small stab incisions. Okay, now this is another lysthesis. This is not so high grade. This is low grade, kind of a grade 1 lysthesis. As I said, again, we place screws on one side. Now, if it is a non-stenotic canal like this, we, as I said, we preserve the normal midline. We do a bilateral laminotomy. We do bilateral facetectomy and discectomy. So we preserve the normal midline if the canal is non-stenotic. So, step number 2, we preserve the midline, and we do a bilateral laminotomy, bilateral facetectomy, and the discectomy. And this is the retractor through which we do this midline work. As you can see, the midline has been preserved, and both the facets have been knocked out on the sides, and the nerves are lying free. And then we go back to the screws which we have placed and fix it, and then we do the lumbar interbody fusion. So this is how we started off. That's the pre-op X-ray, and that's the post-op X-ray. And the post-op CT scan shows the preservation of the normal midline, and the pre-op planning matches with the post-operative CT scan. Post-operative CT scan, those are the small stab incisions. Another interesting case, this is a lysthesis with a severely reduced disc space. So this is a lysthesis with a severely reduced disc space. We learned something during the course of this surgery, and that is what I'm going to share with you. So that's the lysthesis, as you can see, with a severely reduced disc space. Again, we place screws on one side. It was a non-stenotic canal, so we preserve the normal midline. We do a bilateral laminotomy, facetectomy. Now, what we learned during the surgery is this patient had a severely reduced disc space, and we introduced a thin instrument in the disc space, and we turned it sideways to distract the disc space. And this was after the bilateral facetectomy. You can see that both the facets have been knocked out, and this distraction itself reduced the lysthesis completely. So this distraction itself reduced the lysthesis completely. We did not have to pull on the screws. So we kept this instrument inside the disc space to distract the disc space, and which was reducing the lysthesis. And we fixed the rod to the screws in this reduced position. And then we did the interbody. We placed the interbody cage for lumbar interbody fusion, and then we placed screws on the opposite side. So that's the pre-op X-ray. So that's the pre-op X-ray. That's the lysthesis with the reduced disc space, and that's the post-op X-ray. And those are the small incisions. As I said, the largest incision is around 3.5 centimeters. Okay, now that's another significant lysthesis on flexion. As you can see, that's a significant lysthesis on flexion. Even in neutral position, it's a significant lysthesis. That's the X-ray. It's a significant lysthesis. And again, as I said, we place screws on one side. We preserve the normal midline because it's a non-stenotic canal. And this is the final picture. So this is how we started out. That's the pre-operative X-ray, and that's the post-operative X-ray reduced and fixed. Now, during the course of our practice, we realized that actually we are able to reduce and fix the lysthesis only by unilateral screws. So we were actually placing the screws on the opposite side to just buttress the fixation. So we started thinking as to whether we can just use unilateral screws. If we use unilateral screws, that would actually keep if you have adjacent segment disc degeneration, if you require adjacent segment disc surgery in the future and you need to fix, then if you do not place screws on both sides, then actually you can still do a percutaneous surgery without opening up. So that's why we started using even unilateral screws. So that's a case of an unilateral screw. So that's the preoperative X-ray that's reduced and fixed with lumbar interbody fusion and unilateral screws, and you can note the bilateral facetectomy. It was a non-stenotic canal, so we preserved the normal midline. As you can see, it's just unilateral screws. Another one, this is the lysthesis in flexion. This is quite an unstable spine. In extension, it reduces significantly. Again, this was treated using unilateral screws. So that's the pre-operative X-ray, the post-operative X-ray. This was a non-stenotic canal to preserve the normal midline. Unilateral screws, that's the patient. Lysthesis increases over time. This patient had a pretty stable lysthesis from 2007 to 2012. And then from 2012 to 2014, the lysthesis increased. And this is the level of the lysthesis. And this is a lysthetic stenotic canal, where I would probably prefer a laminectomy of the upper slipped vertebra instead of doing a bilateral laminotomy. And so this is what we did. So this is the preoperative X-ray, and we knocked out the facets and reduced it completely, screws on both sides. That's the lumbar interbody fusion. So that's the preoperative X-ray. That's the postoperative X-ray. And those are the incisions. Okay. Now, another case, this preoperative X-ray, that's postoperative X-ray, that's the lumbar interbody fusion, bilateral facetectomy, and it's reduced and fixed completely. Another preoperative X-ray, that's the postoperative X-ray. Those are the incisions. Another lysthesis, case of lysthesis. So that's the preoperative CT scan. That's the postoperative CT scan. That's the preoperative CT scan. That's the postoperative CT scan. You can see the bilateral facetectomy. You can see the lumbar body fusion. This one we use unilateral screws. Another one, this is the lysthesis. This was the level of the lysthesis. So that's the preoperative X-ray, and that's the postoperative X-ray, reduced and fixed on one side. We used only unilateral screws in this. So that's the unilateral screws. Another one, this is lysthesis at this level. We used only unilateral screws. Another one using only unilateral screws. So that's the preoperative X-ray, as you can see, showing significant lysthesis. Again, screws on one side, minimal access line release. This is a lysthetic canal, as I would say, where I would prefer a laminectomy rather than a laminotomy. And that's the final picture. So that's the preoperative X-ray. That's the postoperative X-ray. Those are the small incisions. So this is how we do our preoperative planning. Another case in which we use just unilateral screws. So that's the preoperative X-ray. That's the postoperative X-ray using unilateral screws. So that's unilateral screws. Now, this kind of a lysthesis where the CT scan shows that God has actually fused this lysthesis, I would not try posterior reduction because God has actually fused this lysthesis. So you cannot reduce this lysthesis unless you break the bone, which I think there is no point. So you can just relieve pressure on the nerves, and you can fuse it in situ rather than trying to reduce it. So we have treated around 171 lumbar spondylolisthesis by this approach. I mean, reduced and fixed. 131 were low grades and 40 were high grade. And nearly all have near complete reduction. We have a median follow-up of 5 years with no loss of reduction. We have no post-op complications except for screw hole infection in one case, which was managed conservatively. So basically, spondylolisthesis can also be reduced and fixed using reducible percutaneous pedicle screws, along with a minimal access midline approach. The minimal access midline approach is used for release, and the release is done by bilateral facetectomy and discectomy. The minimal access midline approach is also, besides release, it's also used for the lumbar interbody fusion. Now, we have been using even unilateral screws for low-grade lysthesis, though I would not say that that's the rule. I think unilateral screws may be useful in later cases of adjacent segment disease, where if you have adjacent segment disease and you need to place screws, if you have unilateral screws, you can still go percutaneously. But if you have placed bilateral percutaneous screws, then you cannot go percutaneously. So that's the end of my talk. Thank you.
Thank you very much, Sujoy, for your wonderful presentation, and thank you very much again for taking over Prof. Mizuno's presentation. It's very wonderful to see you again. So we already have a lot of questions coming up in the chat box. So we will take turn between me and probably Lucia to ask the question. First, question to Professor Guziardi from Muhammad Azam. In one level pathology of this, do you always place the interspinous or interlaminar device? And how about long-term follow-up compared to with the non-device group?
Okay, thanks, colleague Azam, for your question. I think that I like to clarify one point. You must use this device when you like to fuse or to perform one arthrodesis to one level. So I use the device when I like to perform a fusion. That means one arthrodesis, or that means when you like to stabilize one segment. And about the long-term follow-up, at the moment we are arrived in our experience, but not only our experience, because this device, they start to use this device in some other country in Europe with not so long follow-up. But in our end, we start to have a follow-up about 3 years. And what you achieve about the arthrodesis or about the stability of the segment after 6 months, that is what remains after 2-3 years of experience. And what I can say that this device is like a biological device, because you put in contact bone to bone and not titanium and bone like some other device. So I think that the device is more, we can say in bracket, biologic. And when we go to use this device, we can stabilize immediately 2 points, the interspinous interlaminar space and the facet joint, like I showed you before. Thanks for your question.
Thank you for your clear answer. So the second question from Fajar Herbo. Thank you for nice presentation. Question to Prof. Guziardi. Is there any specific indication for using your interspinous and interlaminar facet implant device to achieve better result compared with other implant device based on your experience? What about the cost compared to other technique?
I don't see the question, Asmin.
Yeah, it is in the chat box to panelists. Chat box, there are they use either Q&A
on chat box, sorry, not in Q&A.
I don't see the question. I can't understand well which is the question.
In the chat room, Professor.
In the chat, there is
not
Q&A.
In the Q&A. In the chat room.
Chat room.
Okay, I found. Yes. Okay, and yes, thanks. Sorry, because the question was not on the DNR, but on the chat. So about any specific indication for using your interspinous and interlaminar facet implant device to achieve a better result compared with the other implant device based on your experience. And how about, this is also a very important question in this moment, the total cost. So we can say the indication, I can repeat, is when you like, is your indication to stabilize and to fuse one segment. What I can recommend when you start to use this device, you cannot use immediately for spondylolisthesis. And also with experience, I use the device when we have a slipping, we can say a mild spondylolisthesis, that means 4-5 millimeters. And it's very important to use the dynamic X-ray, because if you have one big increasing on the stability of the segment, I prefer to use a screw. But if you have a slipping of 4, 5, 6 millimeters, that don't increase too much, or that you can reduce when you positioning your patients, you can use this device. About the cost, you must compare the cost is quite the same of the cost of 4 screw and 2 rod. But don't forget, I know that in the market we found also some 4 screw and 2 rod that it's a very, very, very low price. But in Europe, this is not possible to use a material that have not the certification. So that means that you must have, when you use 1 screw, you must control which is the place in which you take the titanium and so on. So the cost of our device is the same of a 4 screw and 2 rod of a good quality. We can say in bracket, good quality. And it's not more expensive.
Thank you very much for your...
You're welcome.
So we move to Professor Hafid, but Gujadi stay. There may be a question for you later. So this question to Prof. Hafid Bajamal from Imran Harsam Kamal. So with regards to microscopic approach for degenerative spinal disease. So in your experience, have you ever been in experience where you met an unexpected condition intraoperatively and have to perform unplanned decision? So if so, could you please elaborate on your experience? So what was the intraoperative finding and what technique do you perform and how was the outcome?
Thank you for the question. Thank you, Azmi. Thank you. So in my experience, based on the MRI evaluation preoperative and dynamic X-ray, so far I never got a problem with during surgery, because in MRI we can completely have an excellent figure of the condition of intracanal or foramen. So far, I don't have a problem. Maybe the other colleagues, maybe.
Sorry if I like to do a little comment. This is a very important question about this surgeon, this colleague, because I think that in our experience, it's not possible to prevent before the surgery each time of problem. What is important, and for this reason I appreciate very much the presentation of my friend Bajamal, is that you must perform, before to perform one decompression, you must perform the dynamic X-ray to be sure that you are not in front, not only a simple stenosis, but the stenosis in one lysthesis, in one instability. This is the first point. The second one can be really what I appreciate very much on the presentation of Professor Bajamal is the conclusion. Minimal invasive spine surgery don't need little skin incision, less damage to it, but need to perform, to achieve the result with the minimal damage for the patient. But you must decompress. Anyway, you cannot have a good result. I remember one old discussion with Professor Sontag some year ago in a meeting in South America, when we speak about this different technique to perform one lumbar stenosis decompression. And he said, for me, it's not possible to decompress bilaterally from one side. And I say, oh, Professor Sontag, I am really very surprised about your experience. You use more this type of a Christmas tree decompression, and it's a very good technique for sure. But what is important, and Professor Bajamal showed really very well the problem. If you must go bilaterally from one side, you must take out the basis, the inferior part of the spinous process. This is the tricks. Anyway, you cannot go to the other side to decompress bilaterally. This is my experience, and I like to say again, thank you very much to Professor Bajamal to really underline this problem. You must take out the basis of the spinous process. Anyway, you cannot go on the other side.
Thank you, Gurziadi. Maybe Sujol, you want to share any unexpected cases where you have a complication, you have to change your strategy?
I think the biggest risk for in minimal access lumbar spine surgeries is dural injury, and I think all of us in our practice have faced this sometime or the other, and I think it's important to be able to manage dural injuries properly. Because you know, CSF leaks can have devastating consequences. So you know, that's a topic by itself as to how you manage dural injuries during minimal access lumbar spine surgeries, especially in really stenotic canals. You know, really stenotic canals, despite your best efforts, you might end up with a dural injury. So you know, I would be interested in knowing as to how the other people manage their dural injuries.
Maybe Prof. Afif.
Yes, thank you, Sanjay. Thank you, Sanjay. You know, I prevent the dural injury very good. I use bone work only with drilling, never use Carrison. And then only Carrison only if I need for the flavum. Before I did an excision of flavum, I insert the cotton in some place, small and very thin cotton, to prevent from dural injury. So I never got a dural injury so far. But in another operation in laminotomy, tumor, and so, if I have a dural injury, then the best treatment is to give a stitch and then put a small muscle stem. Is the best muscle stem is the best to close the dural tear after you put a stitch in. That's my experience.
Does anyone just use tissel or just fat as a solution if you have a dural injury in minimally incised, because very difficult to stitch?
I actually think I have had one bad experience in this talk which I gave was on spondylolisthesis, but this was a case of lumbar canal stenosis. I remember it was a severe lumbar canal stenosis. I did not place screws in that patient, just decompression, and I made a small dural puncture, and despite the best of my efforts. Now this patient had and I used the I repaired it, I placed fibrin glue, etc. But still this patient had CSF leak through the skin, and I had immense difficulty in managing it. Thereafter, I had another case, another similar such case. Now, you see, the problem is if you have a small dural tear, you may end up with a ball valve kind of situation where CSF escapes. A ball valve kind of situation where the CSF escapes. It's a one-way egress of CSF. So in those cases, it might be an interesting thing to increase the puncture a little bit and then apply a suture. because if you increase the puncture a little bit and then apply a suture, you can actually get a better seal, and you don't create a ball valve kind of mechanism for the CSF to escape. So I used this for my second case, and I did not have any post-operative complications. So I am very careful in trying to prevent dural injuries. But I have had 4 or 5 cases in my life. The first one, as I told you, I faced a lot of trouble when the patient had CSF leak through the skin wound. But thereafter, I've been able to manage, by actually extending the dural tear a little bit and then repairing it. And I also use fibrin glue along with it.
Okay, we have more questions coming up. One from Anonymous to Sujoy.
Yeah, all the questions are for me, actually.
Yeah. Okay. Pertaining to, is there any statistical analysis study compare your method?
I can see, Azmi, I can see those questions in the question and answer. So I can answer.
All right. So can you answer that?
Yeah, I will. So this question from this
Anonymous.
He asked, the question is, have you or your institutions performed a statistically analyzed study comparing my method and the more common ones using C-arm? No, I have not performed any statistical analysis. Actually, I still use C-arm. It's not that I don't use C-arm. I still use C-arm, but because I do the pre-operative planning, my C-arm, the X-ray exposure time, especially the AP anteroposterior X-ray exposure time, has been minimized significantly. But it would be worthwhile to compare it with another kind of method. But you see, I have stopped placing open pedicle screws, so it's difficult for me to do the analysis. Now the next question from him was that what happens if patients with obese patients. Actually, I feel percutaneous pedicle screws are extremely well suited for obese patients, because open pedicle screws in obese patients would entail a very large incision and a lot of dissection. And I think percutaneous pedicle screws are a boon for obese patients. And the technique remains same. You simulate the screw insertion from the skin through the pedicle into the vertebral body. And so it does not matter whether the patient is obese or slim. Okay, the next question is from Muhammad Azam.
Yeah.
Okay, how do we prevent misplacement when we look and measure at the axial CT, but the patient is positioned in prone position with lumbar? Yeah, the position changes. Yes, correct. So his question is, I do the planning on a CT scan when the patient is supine and the surgery is done prone. You see, Dr. Azam, I do the planning only for measuring the distance from the midline and the mediolateral angle. So whatever the position of the patient is, the mediolateral position of the vertebra does not change. What changes is only the craniocaudal angle from a prone position to a supine position, from a flexed position to an extended position. What changes is only the craniocaudal angle. The mediolateral angle does not change, because the body itself will remain the body. It cannot change even if the patient is flexed, extended, supine, prone. So actually, the mediolateral angle does not change whether you do the planning on the CT scan. It's the body will remain the same whether the patient is as in the CT scan while during surgery. Okay. The next question is from Aji Setia. Is there a criteria of patient selection when done open surgery versus percutaneous surgery? Actually, I do all my surgeries percutaneously. So I I have stopped doing open surgeries. So I think all lumbar screws can be placed percutaneously. The next question is from Rizki.
Yes.
What is the most common complication? That's my last question. After that, it's all questions for Professor Bajamal and others. What is the most common complication of percutaneous pedicle screw placement? Well, you know, the common complication of misplacement, the most common complication would be misplacement. But if you do your planning accurately, and if you are careful during surgery, you will not have misplaced pedicle screws. And actually, we have come to realize that the accurate preoperative planning is probably even more important than the intraoperative X-rays. So, so if you actually do your planning properly preoperatively, you are not going to have misplaced pedicle screws. The next question is for Professor Bajamal.
No, you have two more questions. Two more.
No, I think the next
question after Professor Bimba, you have two more questions at the end.
Oh, okay. Yeah. Yusuf. Yes, spondylolisthesis with obesity.
Yes.
Is it favorable to do percutaneous pedicle screw? Yes. Obese patients, perfect patients for percutaneous pedicle screws. How do you maintain the anatomical trajectory? Just stick to your preoperative planning while inserting the screw in obese patients. And use the lateral X-ray for the craniocaudal location and the craniocaudal angle. And yes, the last question is an interesting question. Direction of use of pedicle screw in patients with osteoporotic spondylolisthesis, short or long segment. Okay. Now, if I have osteoporotic patients, I use the osteoporotic fenestrated screws. You know, the fenestrated, you can place those pedicle screws, and then those screws are fenestrated, and you can inject bone cement through those screws. So these fenestrated percutaneous pedicle screws are a real boon for osteoporotic spines. I actually never prefer long segment fixations. So even for osteoporotic spondylolisthesis, if I'm able to achieve reasonable reduction and good fixation, with screws which are firmly placed in the bone, I would not go for long segment fixation. I hate long segment fixations. So that kind of answers your question regarding short or long segment. The rest of the questions are for Professor Bajamal and Professor Guizadi.
So back
Thank
to
you.
Professor.
I have two questions. I got two questions, Dr. Benvenuti. Can I ask?
You have two questions, yes.
Yes.
Can you read it?
Yes, okay. First is from Dr. Ahmad Agus Faisal. Thank you for the question. He asked about the post-operative daily treatment for the patient. Now, I think this is an important question because we have to continue control the patient and given an advice how to do the daily living. The first problem is body weight. Body weight is the first problem for the canal stenosis. So I advise always to control the body weight. And the second is to strengthen the muscle, the balance muscle between the abdominal muscle and the posterior back muscle. The best one is by swimming twice a week. This is enough if we continue to do it. I think that is the best one. And further, there is no special. But, you know, there's the degeneration process. There's the patient every 6 months have to come to discuss the condition, and we can make a new picture to see the condition. That's the first question. And to my great colleague, Dr. Fasu, thank you for your question. So I told you that most of the bone work I use by drilling, high-speed drill. I'm very satisfied with the high-speed drill. It's never injured the dura. But you have to use a low speed. If you're going to the place where it's dangerous, then you have to do low speed. Carrison is only in sometimes if I difficult to get flavum from far away from the opening. Sometimes I use Carrison, but Wills approach, I never use Wills approach. I use simple subfascial approach and doing a simple retractor. Thank you, Dr. Fasu. That's all for me.
I think the second question from Basu is to Sujoy.
Yeah. It says that intertransverse fusion. I actually don't do intertransverse fusion. I do lumbar interbody fusion. Okay. And he asked me whether I use paramedian Wills approach. Yes, before I started placing percutaneous pedicle screws, that was, 12, 14 years back. I used to use the paramedian approach because I've always hated muscle retraction. So I used to use the paramedian approach to land directly on the screw insertion sites. But I don't use it anymore because after I use that as a kind of a learning curve as to how to learn to place percutaneous pedicle screws. But once I learned placing percutaneous pedicle screws, I stopped using paramedian Wills approach. So before I learned placing percutaneous pedicle screws, I used the paramedian Wills approach to place open pedicle screws. So because that's the trajectory of the percutaneous pedicle screws. So I wanted to learn the trajectory in an open fashion before I moved on to the percutaneous pedicle screws. But once I learned percutaneous pedicle screws, I have stopped using the paramedian open approach. That's my answer to that question.
Okay, thank you very much. Maybe I would like to invite Professor Armando Basso and Professor Ahmad Zodi, if you can come out. Maybe you want to give some comment or question to the speakers. Professor Basso, Armando Basso. Ahmad Zodi. Okay, never mind. So Lucia, do you have any other question to the speakers?
No, if I think that speaker answer to all. There is one to Professor Guicciardi in question answer, but I think that is already, no. Do you always place the interspinous interlaminar device? And how about long-term follow-up compared with the non-device group?
Lucia, I asked before to this question.
I think that you already asked to this. Okay?
Yes, sure.
Okay. For this, I have no other question. So if there are no other questions, I think we can conclude as me. Yeah. That's right. And I want to thank all the organizers, all the speakers for their very nice presentation. We learned a lot from them, and we bring home large experience from their presentation. I want to thank my co-moderator for his assistance, and in time of rest, I want to thank, of course, all the attending colleagues to this webinar that represent kind of be back to the normal life, and this is very important in so black period that we have been living. And for this, I want to let you have a message, a special message of hope that it's true that life is not about waiting that the storm pass. It's about learning to dance in the rain. Today, we have been dancing, and I hope we want to continue to the dance. Thank you.
So maybe before we close the session, I would like to invite Asra to tell us about next activity and also the numbers of participants that joined us tonight. So Asra?
Yes, thank you, Asmi. So now our webinar is include about more than 100 participants now. So thank you for all the participants. And also it could be maybe in the next month we will have another interesting topic about our webinar that every month we try to make some excellent webinar from this ISMINS committee. And also we decided that our ISMIN Congress will be conducted by virtual Congress in next September. So 3 days with 1 day virtual workshop too. So I hope Professor Guizardi, Lucia, and always my friend Sujoy can involve as a speaker in that meeting. I think that's all, Asmi.
By September, COVID will be gone.
Yes.
I said by September, COVID may be gone.
We cannot guarantee it.
No. At moment is out of the door. This is the problem. We hope that we can open the door in September.
Yes, I hope so.
We hope.
Yes. So please.
In India, everything's open actually.
India always.
We have achieved herd immunity. Herd immunity.
Yes, I've heard from the news.
Yeah, so
okay.
Next month. So next month we will have actually a 2 monthly webinar.
Yes.
Then in between we put a special session on new technologies.
Yes.
So the last one was on confocal microendoscopy, and the next one will be on omniscient connectum, something like that. So we will make the announcement. Please join us next month exactly on Friday in March, sorry. Yeah.
Yes.
So thank you again on behalf of Professor Yoko Kato. She could not join us, but she always in communication to help us. So thank you to Professor Guziardi, Professor Hafid, Sujol again, thank you very much, and Lucia, and of course my good friend Asra for joining us, and his team from Erlangga University, especially the team who really work hard to make sure everything is successful. So stay safe till we meet again.
Asmin, Zara like to take a picture before we close.
Yeah, okay. All right.
No problem,
Zara,
no problem.
And everybody,
Zara, I had a picture. I'm going to send to you. I already took it. You want, you can take again, but I took a picture during the discussion.
Thank you, Lucia.
we make another group photo, Zara?
Yes.
So
Yes.
Zara, go.
Okay, 1, 2, 3, smile.
Smile.
Okay, thank you very much.
Okay, thank you.
Okay,
Thank
thank
you.
you to everybody, and a
Thank
big,
you
big
to
hug to
everybody.
everybody.
Yes, thank you.
Ciao,
Yes.
Ciao.
Thank you.
ciao,
Bye.
ciao, ciao.
Sujoy, goodbye, Sujoy.